Welcome, everybody. Core 20+5 Learning Week 2025. Ooh. So, who am I? I'm Richard Haddad. I'm a GP. I'm at Saltone Windhill Medical Partnership for half of the week. And the other half of the week, I work on system leadership, try and herd GPs around the system. And I sit on the senior leadership board, POE, at the moment, trying to figure out how we navigate through all the changes that we're seeing at NHS England. And I was very excited to be invited to come and chair this meeting by Duncan and his team. My background was very much in community engagement, patient involvement when I first started in these leadership roles. So I've really had a sense in my leadership journey of how important this sort of work is and how it really under the rest of the system's work, and particularly the importance of addressing health inequalities. So thank you for inviting me to come and talk to this and share some of the experiences you've all had in trying to shift our health inequalities dial. Formal bits that I have to introduce. Welcome. Please type your name and your organisation in the chat. Please put yourself on mute so that we can hear the speakers. We'll be recording the session, so if anyone doesn't want to be on camera, please turn the camera off, and there will be an opportunity to ask questions at the end of the session. Try and hold them back and or put them in the chat, and we'll get through them as we go through the session. So just a general introduction around Core 20+5. I imagine most of you know what that's about by now, but we know that across Bradford District and Craven, significant health inequalities in our communities, the gap in how long people live well is pretty stark, with a healthy life expectancy difference of over 20 years. So there was national work to identifying this issue, and Core 20+5 was a national programme introduced by NHS England to approach and support the reduction of health inequalities. So the name, the clues in the name, is targeting a population and +5 local clinical areas requiring accelerated improvement. So in Bradford District and Craven, our approach to Core 20+5 is to reduce the health inequalities for those living in the 20% most deprived parts of our district, to support those in the nationally defined plus groups as well, and to work towards the 5 NHS England clinical priorities. To do this, we work closely with our community partnerships, actually core in delivering this kind of work, and working across those sectors that can really enable work, and aligning the Core 20+5 priorities to locally determined plans to reduce those health inequalities. Of course, we've probably been on with looking at health inequalities longer than Core 20+5 has been going on, so aligning the two was not maybe so hard. The resource has been distributed a little differently on this occasion. We've distributed it proportionally according to need and deprivation indices, rather than just a straight flat share across population, which is like changing things. And the programme has been overseeing the delivery of around 70 projects involving a range of partners. So what we're today to do, well, this is the Learning Week, highlighting what is working in our approach to Core 20+5, share the learning and celebrate what's been achieved after nearly 3 years of work. Gosh, has it been 3 years? Look at that. So we want to support attendees to apply this learning in your own areas of work. If you want to find out more about the 20+5 programme, please join the others of our 5 sessions during this week, and we can post a link in the chat around that if you want to have a scoot around those. So we thought this would be a good time to air our findings. The government's just dreaming up its 10-year plan at the moment, its 10-year strategy, eventually. And core to this is the much publicised shift from treatment to prevention, and the move from care from hospitals to communities, which of course we've all been desperately trying to do for years, but really struggling to do. So nice to have some national backup on that one. This is both very relevant to our local work. Reducing inequalities is something we hope to embed in our emerging integrated neighbourhood health programmes. So that, I suppose, is the new lingo for care coordination, integrated care, risk stratification. Goodness, we've done all sorts along the years, haven't we? But we're now calling it integrated neighbourhood health, and there's a dedicated programme in our new structures to oversee that, and I think these programmes of work will really contribute meaningfully to that. So the session specifics today, we're going to focus on the 5 clinical priorities. We're going to look at the 5 clinical outcomes set in the core framework, for example, cancer health, heart disease, mental health conditions. These are the clinical areas that we see the greatest health inequalities across the country. We'll share learning from a range of projects designed specifically to target those clinical outcomes. We're joined by Aaliyah, our Reducing Inequalities Manager, to hear about the overall findings of the project, and then some specific updates from Abby on maternity circles, James on our project, and Carlton from our family crisis project. So it's time for you to seek some glory, because you're quietly beavering away in the background, you lot, and very rarely celebrated like the rest of the system gets recognised. So I think it's time to uncover the unheard of heroes. And so to do that, I'm going to hand over to Aaliyah, first of all, who I think is going to give us an overview of the programme's work before we get into some of those 3 specific cases.
Fabulous. Thank you so much, Richard. You were slightly jittery there, but I think we got the gist of it. So hi, everyone. My name is Aaliyah Fazal. I'm the Reducing Inequalities Manager. And over the last 3 years, I've had the pleasure in working with our community partnerships to support some of the Core 20 interventions. And we're going to look at some of those across these 5 clinical areas. So we had maternity, ensuring continuity of care for pregnant women from Black, Asian and minority ethnic communities from the most deprived groups. We have severe mental illness, which was ensuring annual health checks for 60% of those living with SMI. And that's a very specific cohort piece of work. Chronic respiratory disease, a clear focus on COPD, driving the uptake of COVID and flu, and to reduce emergency hospital admissions. Early cancer diagnosis, specifically at stage 1 or 2. And we also have hypertension case finding to allow for interventions to optimize blood pressure and minimize the risk of stroke. Smoking cessation was a cross-cutting theme. And we also had a locally added outcome, which was prevention and early help for children and young people to reduce adverse childhood experiences. The community partnership also had sort of aligned priorities of their own. So, for example, improving health literacy in their specific wards to improve better understanding of prevention, but also improve self-management of their long-term conditions, amongst others. Next slide, please. So you probably won't be able to see that here, but my colleagues will share the logic model and the theory of change in the chat. But we started off with a very detailed logic model highlighting each clinical area of what needed addressing, what we will do, how we will go about doing that, set of outputs and indicators. So each intervention that we have developed was supported to have a set of indicators to perform against, what the short-term outcomes would look like per intervention and how they would be measured, and also the long-term, so whether we have reduced inequalities and what will have changed. So please feel free to have a look at that because it is a very detailed piece of work that our colleagues put together. Next slide, please. So as Richard mentioned, we have been working across a community partnership footprint. So they were all received a data pack that looks similar to this table. As you can see, this was kind of like the before 21, 22. And this really helped the prioritization using both data-driven and health-focused approaches to support them to develop interventions that will look at these specific indicators. 6 of the 13 community partnerships that ranked the lowest in what we call index of multiple deprivation had key comparisons. So whether that was high rates of smoking, late antenatal booking in pregnancy, high premature mortality from all causes, high emergency admissions, low uptake in vaccinations, low uptake in cancer screening, and high prevalence of other long-term conditions like diabetes. So alongside this, we had other data that we were able to analyze based on the wards which those community partnerships represented to really help us to think about what were our top priorities and what interventions they would like to put into place. We will be sharing a lot more in detail on this tomorrow in regards to how we have been closing the gap on some of these indicators. So please do tune in tomorrow. Next slide, please. So here is a little snapshot of some of our intervention against each of those clinical areas. So for maternity, we had interventions like maternity circles, which have been delivered in locations with diverse communities. We've further embedded NHS maternity systems. We've had other interventions like preconception training for the workforce and vaccination uptake, particularly RSV, respiratory virus, and looking at perinatal support. where we would have had SMI, we've concentrated on mental well-being, because the SMI is a very specific cohort of individuals, which as a system we're doing pretty well. So our community partnerships focused on more mental well-being, looking at interventions like counselling, holistic support, mini wellbeing hubs that's supported with substance misuse and welfare support, physical interventions that help improve mental health, alongside, and all these projects have been supporting an increased access to the mental health services. And we've also had specific group interventions focusing on older people, dementia and men's mental health. Under respiratory, we've had interventions that have been around respiratory physio, which was a specific gap that was identified, offering support either within clinics and patient homes. We also have the Breathe project, which you'll hear a little bit later today. And they've done a lot of engagement around smoking cessation services. And essentially, these have supported improved clinical outcomes, reducing COPD exacerbations. With cancer, we've had interventions that took a community-led approach, training and developing community champions. And we heard about the KCAM project on Tuesday, and again, raising cancer awareness. And these have supported the increased uptake of routine cancer screening through culturally appropriate health messaging. For CVD, we've had community health checks model and health coaching models, and they have demonstrated they can improve access to activities to improve health awareness, but also identifying new patients with CVD risk. And under our ATR, we've had a range of interventions, so supporting children and young people and their families to increase resilience and well-being in school and whole family settings, projects like mobile adventure, outdoor play, co-production of health messaging videos with young people and family crisis. And I suppose what isn't represented here is some of the additional work that the Core20 has been involved in, such as supporting the uptake of vaccinations, seasonal flu and COVID, partnership working across our primary care networks, and additional funding we've been able to secure to either extend some of these models or expand across the district. Next slide, please. So the distribution of interventions is illustrated here in this table, and the number of interventions implemented. So we have a total of 73 that were developed. Some are quite unique, as in they're the only one, and others are models that people have adopted, such as the community health checks or maternity circles. There was a predominant emphasis on the theme of adversity, trauma and resilience, as you can see in the blue tabs. Additionally, highlighted in pink is maternity, again, a key focus across our community partnerships, and again, data that informed us of infant mortality data. In the dark purple, we can see community partnerships that adopted the community health checks model. And some of the feedback from our community partnerships also indicated they had a preference to concentrate on primary prevention, as well as the broader scope. So you can see in the green, almost all our CPs had interventions that supported mental health and well-being. Cancer and respiratory in orange and light purple being the fewer interventions. And as Richard said at the beginning, funding was allocated proportionally across the community partnerships based on deprivation data. So therefore, some of our community partnerships had the flexibility to implement multiple projects, as you can see more towards the left of that table, and they were able to sort of focus on multiple priorities, whereas others on towards the right opted to concentrate their investment on what their top 2 or 3 priorities were. And we have a far right table, which is highlighted in blue for district-wide, and that was a very specific ATR project called My Happy Minds, and that alone reached 30,000 young people through schools. Next slide, please. So here we have the first chart broken down of participants. We have had 15,337 people supported through these interventions, which is absolutely amazing. And on the right chart illustrates the extent of engagement within our more socioeconomically deprived communities. And we have a much more in-depth presentation that we had on Tuesday. So whilst the previous slide indicated that interventions that targeted cancer and respiratory were fewer, the initiatives that were implemented were much more strategically focused. So they used more GP patient lists and referrals. So the respiratory physio project to effectively reach individuals who were housebound, who had missed their normal appointments or were at risk of hospital admissions. By having more of a targeted approach and visiting and offering the support in their homes, they were able to reach 82% from the IMD 1 and 2. And that was similarly for cancer. They've been using GP text messaging and a community engagement approach to invite people for cancer screening programs and thus reaching a 90%. So this is an indication that participation numbers are not always a measure of success for some clinical areas, because having more of a targeted approach with the data, with the partnership working, meant we could reach those most in need and in the core 20%. Similar strategies for other interventions with maternity circles, ATR, and summer health checks, using a combined outreach targeted approach, whether it was through GP text messaging or using our VCS organizations for community engagement. You know, another example we have is maternity circles. It is designed to target pregnant women in our IMD 1 and 2, but we have a very much of an open access drop-in support, so we can support the broader community like dads and carers and partners. There's a combination of ways that our interventions have engaged. And projects that fall into the cross-cutting themes were projects like health champion roles, health messaging, and they've used bilingual members of the community, being really creative by creating resources in various languages and videos. So hoping that's given you a little bit of a flavour of the breakdown of the interventions. I wish I could go through all 73, but I can't, I don't have the time. But you're going to hear amazing stuff from our next speakers who will go in a little bit more detail. Back to you, Richard.
Well, that's a baton straight on to Abby, I believe. So we're moving straight into the maternity circles. 15,000 patients. People, sorry, Dr. Mode here. That's a lot of people, isn't it? That's a lot of folk. Impressive. So, Abby, are you ready to talk us through the maternity circles work?
Ready as I'll ever be. Thank you. Okay, so my name's Abby Wild. I am the project manager for Family Hub Start for Life, but in my previous role, I was the programme manager for the Best 1001 Days, and before that, the Better Births programme, and that's where this all started. So that's why I've been invited to come and speak to you about maternity circles, because I've been involved in it right from the very beginning. And later on, we did commission maternity circles through Start for Life, and we have maternity circles in our hubs. So little bit of the history. I am a midwife by trade as well, and that's what really drives my passion for improving outcomes for the families of Bradford. So I've been in this role since April 2024, but like I said, I was involved in this work before that. So next slide, please, Jo. So where did it all begin? So it started off back in November 2021, when we had some community engagement events in Keighley and in Bradford. And we spoke to lots of new parents and expectant parents, and they told us that they were feeling isolated, that they didn't know where to go to access a range of support during their pregnancy and that those the early stages of parenthood. I always remember one particular mum that stood out to me who had an 18-month-old with her on the day, and she said, "My baby hasn't been weighed since it was 2 weeks old. I don't know where to go. I don't know who to ask for support. I never see anybody," you know, and she just felt really, like I say, isolated and not knowing where to go for that support. We also recognised that there were particular disparities in our community which affect many of our families, and serves as a barrier to accessing perinatal support. So those barriers include the cost of living, loneliness and isolation, which could be a reason for not accessing perinatal support, but could also be, you know, could not accessing perinatal support could lead to loneliness and isolation. Poor maternal mental health and well-being, a lack of awareness of where to go for support, and poor literacy skills, which relate to education and language barriers. Next slide, please, Jo. So there are lots of quite terrifying statistics that tell us that the outcomes can be really poor, particularly for women who experience multiple complexities in their pregnancy and early parenthood. And some of the stats from the 2025 Embrace report tells us, you know, just how concerning these facts are. So the report looked at the care of 643 women who died during or up to a year after pregnancy in the UK and Ireland. And of those 643 women, 91% of them faced multiple interrelated challenges. Many women experienced severe disadvantages, including social services involvement, past trauma, domestic abuse and deprivation. And maternal suicides continue to be the leading cause of death between 6 weeks and up to a year postnatal. And there's a wealth of evidence which demonstrates a causal link between loneliness and isolation and suicide, and the protective effect of social support against suicide is really well documented. We also know that women from Black ethnic minorities are still more than twice as likely to die compared to white women. And while this represents an improvement from previous years, the report reiterates that this should not be misinterpreted as progress, as Black and Asian women continue to face disproportionately higher risks during pregnancy, childbirth and the postnatal period, and inequalities in experience remains a significant issue. Next slide, please, Jo. So what exactly is a maternity circle? I asked exactly the same thing when we had that very first engagement session in Keighley back in November 2021. And it was actually a service user that suggested the idea to me. And I had to go away and start Googling what a maternity circle was. And I learned really quickly that, you know, they weren't common, but it sounded like a brilliant idea and a fantastic way to tackle some of the issues that we were seeing in Bradford. So it's designed to be a one-stop shop for all things perinatal, from conception through to early parenthood, ideally within pram pushing distance from home. So we responded to the voice of the community and we considered the evidence that relationship-based models and access to enhanced perinatal support can positively impact birth outcomes. And we know that peer support can be beneficial during pregnancy and the postnatal period as well. So there's evidence to show that women value peer support relating to several themes, including interpersonal sharing, feeling socially connected, attachment both to peers and their babies, and having access to information and practical support. So a maternity circle provides a welcoming environment. So it's warm, friendly, non-judgmental, and a space to connect with others on similar journeys. A maternity circle provides information and advice, so information and support related to maternal health, well-being and parenting. And expectant and new parents are more receptive to receiving information during that time. So it's an ideal time to give, you know, health education and important messages, and even more so when it's accessed through places that are familiar to them. A maternity circle provides parent and baby activities such as play sessions, baby massage, first aid, baby weighing, maternal journaling, and much, much more. And access to support services, so health visitors, domestic abuse support, smoking cessation, housing, and the list goes on and on. There's often lots of different services come in and visit the maternity circles. We have parent education coming along to provide sessions and things like that. And it's very responsive to the needs of the parents that attend. And community connection. So the aim is to combat social isolation by facilitating connections and building that social support network. And then on to early parenthood, the support for early years. So for the entire parenting journey, from conception right through to when the child is 2 years old. Next slide, please, Jo. So where are we now? So this map shows how far we've come in the last few years. So from that very first maternity circle, which we started in Manningham Mills in, I think, 2022, which was very slow to get going. And we really had, you know, a bit of trial and error to get that moving initially. To now, we've got 11 providers delivering from 18 different locations across the district. 15 of those circles are weekly, 3 of them offer weekends, monthly or bi-weekly sessions. We've got one which offers virtual support, one offering out of hours telephone support. We've had over 1,000 participants, 62% of which are from IMDs 1 and 2, and 46% are from Black, Asian and minority ethnic groups. So we're really targeting the families that need it the most. Okay, next slide, please. So I'm just going to share a couple of case studies just to give you a flavour of what these maternity circles are achieving. So this first one was a 40-year-old mother of a 7-month-old baby. And she'd recently moved from another city where she and her partner were drug users, and they'd been to rehab. So they'd really sort of rebuilt their life and they'd moved to a new area. And this mother was feeling really low in confidence. She felt really judged by other parents. She felt, you know, being a first-time mum at an older age, she felt like she was, like I say, being judged by the other parents that she was meeting. And she was also traumatized because she'd had a previous experience of her baby choking, and she was really struggling with this. She was met through the maternity circle with empathy and kindness, and built a relationship with the facilitator. She gained new skills and confidence by attending the baby first aid course, and she built relationships with other facilitators, and with other parents. She found that her confidence really increased. She felt accepted. She felt safe and comfortable coming to the maternity circle. Her baby was socialised with other babies as well, and she accessed the weighing facilities. And one of her favourite things about coming to the maternity circle was that she was able to drink a brew whilst it was still warm, and that was something that she hadn't been able to do to date. So just that, being able to sit with friends, have friendly support and advice, and be able to have a cup of tea was just what she needed. Next slide, please, Jo.
Abby, sorry, I'm going to have to call. We've used our 10 minutes here, so if you could try and wrap up, please.
Okay, I'll skip past this case study, and I'll just go on briefly to some feedback. So next slide, please, Jo. We'll share these slides afterwards. So I won't read through all of these, but I'll just want to pull out a few of my favourites. So one is that it was very reassuring to know there were lots of resources and help for parents in Bradford. It's been a lifesaver. The group and staff are amazing. Helped me go out more and socialise and gave me more confidence. Next slide, please. So I was going to tell you a little bit about the baby wellbeing event, but we are running out of time, and I want to just touch on this last slide, which is around the infant vaccinations. So this is just a really important one to share because it's been in the news. You may have seen it on BBC News. And we have built on the maternity circle model to implement vaccination clinics in the community, and we've seen infant vaccines rise from around 40% to over 90% in some areas. So this just shows how well this model works. I'll just skip on to the last slide. I'm so sorry. So we've got our maternity circles embedded. We need to continue them to see longer term outcomes. We've seen a massive increase in antenatal engagement, which was one of our greatest challenges in the beginning. We're building on this with an early intervention midwife that's going to include parent education in maternity circles and family hubs and focus on the Black women's health agenda. We're really leading the way on that integrated neighbourhood health agenda, bringing in those the vaccinations, and we're seeing other local authorities wanting to replicate this model, for example Wakefield and Leeds. And my final message is that vaccination rollout, we'd like to see this across the whole district because we know it works. Thank you. There's plenty of links on my slides. I will share these afterwards.
Well, if Leeds are copying us, we must be doing it right, isn't it? So well done, Abby. That's a fabulous presentation. We whipped through that very quickly. Thank you. I'm sure people have questions, but my agenda, I'm going to move through all three and then take questions at the end. So I'm going to move us straight on to James, who's going to talk about the Breathe project. James, are you with us?
Yep. Hopefully everybody can hear me okay.
Yeah, yeah.
So our big project looks at tackling the root causes of smoking. It will be a smoking cessation project, but we don't put the emphasis too much on people when it comes to stopping smoking. We look at why they're smoking and kind of try and tackle it from that point. You can go to the next slide, please. A little bit about us, first and foremost, at Healthy Lifestyle Solutions, established in 2001 with the general aim to reduce health inequalities. I'm not going to go over every bullet point there, but We are based within a medical practice, Tong Medical Practice, up in the Tong Ward. We're based here throughout. A lot of our focus has been building interest groups, kind of establishing them to move on and become independent. So we've set up everything from a visually impaired group back in the early noughties, which is still running independently now, and that's communicating with Bradford Council and others about matters that concern them, to interest groups such as men's groups, knitting groups, etc. We've also been doing social prescribing since 2004, and more recently in 2019, our community partnership work, we set up Restore Recovery College, which aims to deliver around courses and is currently being funded as part of the Community Mental Health Transformations Core Service, and doing a lot of work with individuals around SMA, etc. Next slide, please. Three-part slide to this. Smoking and figures locally. What does it mean? We know from the Old War profiles that adults in our community, we have the highest number of adults who smoke is 22.2% of adults smoke here. And looking at recent System 1 data, that current total is 7,827, of which that fluctuates all the time. In terms of priorities, when it comes to smokers locally and for the community partnership, we decided on 4 local priorities: smokers with COPD, smokers with asthma, smokers who are pregnant, and smokers with SMI. And in partnership with the primary care network, we looked at System 1 patient lists, and the primary care network supporters managed to pull us off some patient lists relating specifically to those. So recent data suggests that we've got 547 smokers with COPD and 913 smokers who have asthma. I actually produced a report the other day to kind of look at who had COPD and asthma. We've had 82 people on our register with COPD and asthma. It gets a little bit more complicated when it comes to smokers who are pregnant. And of course, it's understood that a lot of smokers and people that we're working with and the root causes also have severe mental illness. Next slide, please. Project overview. Again, I'm not going to read through every point here, and I'm sure this out. The real innovation in our project comes from the partnership work that's been done all. When it came to developing the project, it wasn't just ourselves as an organisation that really we brought to the table to say, how do we want this to work? We worked quite heavily with our primary care network, both the PCN manager at the time and GP lead for respiratory health. We also brought on Living Well, because they've got a general stop smoking service from Bradford Council, and other local partners as well. We wanted all perspectives in developing the project on how we can make the greatest impact to smokers in our community without duplicating work that was already done elsewhere. And we also looked at how those projects are reaching smokers to try and sort of tackle that behaviour and look at the root causes, etc. So we brought them on board. That partnership has gone from project development through to recruitment of role. We've included those partners in the recruitment as well, to training, and even continues in effective future project work in the future. So I really want to share that there. Without that partnership and that joined up approach, this project wouldn't be what we consider a success. Next slide, please. Two-part slide again. Our GP practices: Bowling, Highfield, Tong, Ruley Lane and Lowmore. For those, previous slide. For those that know, we're quite a bubble of we're not like some community partnerships where they've got medical practices here, there and everywhere. The majority of ours are based in BD4, and then we've got the Lowmore medical practice, which is just to say to us, which is where the BD4 plus come from. Our work on social prescribing has kind of bled into the Breathe project a little bit, and working with the primary care network, we have System 1 access, and as I mentioned, those lists already. That access has allowed us to look at it as broken down as COPD and asthma smoking patient lists, and where we feel the need is necessary, we can look at those lists in greater demographic focus, which is hopefully going to come into future work as well. So if we want to look at a particular patient list, let's say, for example, COPD and smokers, but we want to target a particular age range, we can do that from those lists. And it's something other partners weren't able to access. Next slide, please. We'll get through this for time. Engagement approach. Nazir, who's our current brief coordinator, should I say, takes a 4-step approach, building trust and listening. She looks down that list, goes through, approaches people on that list, explain who she is, where she's working from. She has signed practice per day per week from our PCN to work from. She works top to bottom on the list and builds with that practice as patient to sort of identify with them what they believe their root causes are and their reasons for smoking. She asks them everything from have they considered stopping smoking to before, to how much they smoke, how much they're spending on smoking, various family matters, etc., etc. And then working with other teams around the community, takes a target approach at supporting that individual. Step 4 is addressed the conversation about quitting smoking. The reality, and it'll show later in one of the case studies, is actually once you start talking about the idea of quitting smoking with people and you're looking at those barriers, many people already start on their journey by smoking anyway. Another area of work we're still yet to fully jump on board with, but training has taken place, is virtual group clinics. It's an idea that working with people one-to-one in a group surrounding, you can have a shared peer knowledge. So by the time you've asked that the same question 12 times round and kind of gone round, many people start to echo the same themes. Next slide, please. Slides have been formatted a little bit weird on the screen, but in colour there, you can see many of the common reasons, and I'm sure many people here have an idea as to what those root causes and root reasonings as to why people smoke in the first place. Some of the most common ones: financial stress, mental health challenges, stress of various sorts, and addiction. A lot of people recognise that they are addicted to smoking, and as much as they want to give up, they know it's there. We have received a number of people who have said it's habits, and we've all received a number of people that actually say they enjoy the process of smoking as much as they know about addiction and they know it's a habit. It's something they can take, and it's very much for them. When other things about their life seem out of their control, it's something that they can do for them. And trying to break that habit above anything else seems to be the most challenging. Many individuals smoke out of habit. Those are coping mechanism. They're worried about weight gain, pain management, mobility, etc., etc. Interestingly, some of the things that are causing their roots are smoking related. So we look at financial stress. A lot of people are complaining about financial stress, but as we know, cigarettes are not cheap. But individuals that we've communicated with suggest that they spend well in excess of £50 a week. Some people even suggesting that they're spending over £100 a week. And we're trying to change their behaviour when it comes to recognising that smoking is causing a lot of this type of stress as well. In terms of mental health challenges and other health challenges, a lot of people can between 21 and 30 a day. People very smoke in excess of 30 a day as well. Almost 80% of people who've approached have said that they've tried stopping before, but just approaching it under I want to give up smoking isn't working for them. Next slide, please.
James, just in the interest of fairness, I'll have to give you your 10-minute warning as well. Sorry.
No, these will be very quick anyway. I've attached 2 slides. I won't focus on the slides themselves regarding assessments. The first one is more about the reduction the support mechanisms are all in there, but it's about the reduction that it meant to that person. That person didn't give up smoking, but we wanted to recognise that we do have an impact to smokers regardless. The second one, which we'll skip over in a second, focuses on actually somebody who's given smoking but needs support for other people in their house as well. Often it's not just that individual in the house that smokes. There's also a bit of feedback there from individuals. If we get to the slide, please. Just some brief figures at the bottom there. Over 1,000 individuals contacted, appointments made, etc. That's over a 15-month period. 75 swap to stop changes have been made. That's an offer that Living Well brought to the table for swapping cigarettes out for a vape. 124 referrals have been made to Living Well Stop Smoking Service. As I said, we're not a smoking cessation project. We're working on the root causes. We refer out to Living Well to do a lot of the one-to-one smoking cessation work, and we've got 18 quits off the back of that. Next slide, please. Skipping ahead. Some challenges and lessons learned. It does take time with individuals alike. Some people we started working with originally fell off, and they've actually come back to us. One size doesn't fit all. Just asking people if they want to give up smoking and providing them with stop smoking options isn't always enough. You need to work around that person as an individual. And I've already mentioned cross-sector collaboration, partnership working, it's highly important. I'll quickly go on to next steps, just to finish off. Well, we are continuing working with Living Well. They've potential for a future offer coming to Bradford, and with our partnership work, they're wanting it to bring it to their BD4 community because they've seen the importance our project has brought to their work and vice versa. And they will be announcing that incentive shortly to do for them. But they also recognise that our approach to engaging people can potentially help them in the future when their targets for helping people stop smoking increase. Thank you.
Fabulous stuff. Thank you, James. Quite a refreshing version around smoking. That I really quite enjoyed that. Nice to think about that differently, because it's a bit of a brick wall that I bang my head up against on a regular basis and think, why can't we just stop? It makes such a difference. So yeah, interesting. We're going to move straight on. Carlton, let's get your one done, and then we should have a little bit of time if we can get through this for some questions for everyone. Please keep an eye on the chat. There's lots popping up in the chat, lots of positive affirmation for this work. Abby's team are getting their halo firmly polished by their colleagues here. And I'm sure the same will be said for James's work in the chat. So keep an eye on that chat as we go through the next one. Carlton, can I hand over to you, please?
Hi, good afternoon, everyone, and here to talk to you about the family support service, or family crisis support service. So it's been commissioned by Horton City Health Collaboration, and with the funds that we've been talking about recently. It's a collaborative service between BACADS, Bradford Community Advice and Debt Solutions, and Bradford Trident, who I'm from. So the problem our service is there to address is the doom of debt. My slides aren't keeping up. The spiral of doom that comes out of debt, and James touched upon that as people taking to smoking as one of those stress management tools they use. But debt really consumes people's lives. It sucks them into this downward spiral of worry, sleeplessness, ill health, further debt. Marital strife, domestic violence can lead to ill health, unemployment, and in the worst cases, homelessness. So it really is a cause of trauma and extreme stress in people's lives that leads to ill health. So it's treating the causes of debt is our prevention service in helping people live healthier lives. Next slide, please. So the family support service offers that helping hand up out of the spiral of doom. The Trident side is we offer immediate emotional support to people, help with their digital exclusion through distribution of SIM cards and an emergency food parcels. Our colleagues at BCADS do the heavy lifting on this project, and fantastic work they do, if I may say. So they offer a medium-term advocacy service to people. So it helps them address and break down the tangled web of issues people have and come up with a detailed plan on addressing each of those and resolving them so they can resume life unburdened by debt and the host of issues that come with it. And the myriad of issues that households come with along with debt is housing, unclaimed benefits, court orders, unemployment, poor budgeting, poor English language, and many others. Next slide, please. So in a typical 3-month window, the service supports 83 households. So this was Q1, 83 households. Within those households, there's 309 people living, and they present about 420 issues that need resolving. 2/5 of those are lone parent households, 1/10 are pensioner households. So quite a mix, but high representation of lone parents. 20% of the adults are on repeat prescriptions from the GP to help them manage the stress and anxiety that debt causes. And there's 184 children in those households. So a lot of children who that stress and anxiety also plays upon through the debt and worry created in the household. We have quite a wide referral routes. So about 1/3 of our clients come from council-funded advice services. So it's quite often people's first port of call when they're reaching that crisis point. They go to the advice services. They give them advice, but they don't help them resolve the issues. About 1/5 come from schools and nurseries referrals. 1/6 just walking off the street, so word of mouth referrals, similar amount from our ward counsellors, and then we've got the Children's Trust, GP and social prescribers, mental health services and others that send people our way. And we're very grateful that we have that well-established recognition of a valuable service in the area, and many ways that people can access the service. The ethnicity of the people we support is very varied. So British Pakistani, British Bangladesh, British white, Europeans, Afro-Caribbean, and increasingly quite a collection of asylum seeker families working their way through the system. Down in the bottom right, we have a very atypical family. So complete opposite of that representation is typical. Next slide, please. So our service helps people get their head above the water. They can take a breath and find stability in their lives once again, and re-engage with society in a much more meaningful way. So in the last quarter, we had £295,000 worth of debt presented through the people that came. About 20% of that we got the debt written off because it was either excessive interest that had accrued or it was wrongly calculated in the first place. So got that written off. Then there was debt reduction orders through the courts, or proving that it was the person that had the debt attributed to them wasn't really liable for it. So about 1/3 of the debt was discounted through that. Just under half we managed to negotiate on people's behalf to get repayments at a much more manageable level. So affordable repayment plans put in place, and about 10% is still on the case workload, and we will resolve it. So about £300,000 worth of debt per quarter. At the same time, we've helped clients gain additional annual income of about £305,000. So this is benefits that people were entitled to that they weren't claiming. So we've facilitated them on those causes. Of the households that came in that quarter, we've helped to stabilise almost half of them, so resolved all their issues. At the same time, we finished off 26 households from the previous quarter, and that completed everybody's issues from the previous quarter, and we've got about half, 46, ongoing into this quarter. Of those adults in those households, about half of them had their prescribed drugs reduced, so reduced dosages, as people were managing to manage their stress and find light at the end of the tunnel finally. So coming off prescribed drugs. And our onward connections are to over 20 agencies across the district that people are assisted into gaining the benefits from. So the average household debt was £3,500 on the way in, and on the exiting we helped them claim on average £3,700 of unclaimed benefits per household. So really shifting people out of debt to being financially viable going forward. We also assisted people in accessing ESOL, so through services like Safety First that were on the other day, and others. Budgeting courses, very popular, helping people to manage their money, helping people set up bank accounts and direct debits so their bills are paid regularly going forward, so no new issues come forward. Helping people find jobs is quite an important aspect it helps with, and resolving housing issues is a very popular one. There's also access to priority utility services, household appliances, resolving court cases and putting actions on hold in emergency cases. Quite varied. Next slide, please.
I need 5 minutes to wrap up at the end, so if you can just finish off in a couple
of
minutes.
Yeah, double quick. So quick case study, household, the breadwinner, the gentleman in the house had a heart attack and a stroke, lost his job because of ill health. After about a year, the whole family was in really bad state through rising debt, food shortages. Their daughter's education was suffering as a result. Bailiffs came round and a neighbour saw this happening and advised the family to reach out to BACADS. They had an appointment the following week, and then a follow-up visit from the home. Action plan was developed, and within a few months the family had a new kicker because their other one was bust. They're on universal credit. They had direct debit set up with the banks, had SIM cards, debt reduction orders to write off any 20,000 grand's worth of debt that was over the family. The wife had been enrolled on ESOL classes, got her first qualification she'd ever got, was absolutely delighted, and they were successful in gaining PIP. And then the comment from the family was that the calmness and reassurance shown by our advisors helped to cultivate hope during a time when they felt completely lost and overwhelmed. And it really is a life-saving service, helping people get their head above water and re-engage in a really positive way. So last slide is just a few takeaways. Every household story is different. but there's, particularly the case if you're a single parent or an aging household, or you have poor or no English, it's a service that's particularly valuable to them. I think one of our keys to success is giving people time and to listen to understand all their problems and come up with a holistic solution, and that advocacy to really drive through solutions and resolve issues for people is absolutely essential. And if you're digitally excluded or no English again, then that is also particularly valuable. Thank you very much.
Fabulous. Well, terribly chaired because we've got for questions, so we should have 15 minutes. But I can see that the chat has served its purpose in terms of connecting folk, and I think, needless to say, people are really quite impressed with all three of your projects, and lots of positive comments coming in. I can see some connections being made across with colleagues wanting to know more about your projects, learn and shed and spread. So that's exactly the purpose of this kind of session, is to try and get those connections, get that excitement, motivation going around it. I suppose let's take any burning questions from folk. I mean, are there any specific questions people need to ask? While people are thinking of that, I suppose it's just, for me, sat trying to fix a £40 million evolving debt gap this year at the senior executive board, and figuring out ways to solve that. I mean, that's a really busy, difficult task, but knowing that this stuff is going on and continues to be really well supported by all you folk out there, is incredibly reassuring for me, because I have been constantly talking about if we don't do this, we'll have a much bigger problem in 10 years time to solve, and that this is the solution for the problem that we're trying to deal with now in 10-15 years time. And what you're doing is laying the foundation for a much healthier population and a healthier health system in the future. And I applaud you all. This is absolutely brilliant work. Has anyone got a hand up? I haven't seen any pop up while I was wittering. No specific questions. So Joe's been firing all sorts of links out into the chat there. So if any of the more information is required on any of those projects, I think you can tap into the Alliance team, and they'll share and disseminate. There's something in my head here about the fact that this does feel still a little bit postcodey, doesn't it? And we're doing hyperlocal in this, and that feels like it worked really well in your different projects. I suppose the general question to maybe the three presenters: how scalable do you think these projects are?
With a bit more resource, we could
was
scale it up
by the government before. Abby, yours was Sure Start, wasn't it, 10-15 years ago?
Yeah, and the government are going back that way with the Best Start in Life. But I absolutely think that maternity circles are scalable. I think every community should have a maternity circle, and that was always our vision when we started out, was for them to be everywhere and to be community led. So there shouldn't be a huge cost attached to it. It should be about people basically organising themselves and then bringing partners in to deliver health messaging and other services that are already out there that families just don't know how to get to. So bring them to the families. That's what it's all about, isn't it?
Mm-hmm. And your approach, James, to the smoking issue. I mean, I've been putting.
Yeah, we think ours is scalable as well in the same kind of way.
Systems, and that's another opportunity. People might open their mind up. There's different outcomes, and into that pre-assessment process into features in a band. So there's loads of ways you can actually mainstream some of these services if we thought about them strategically. What's frustrating is that they constantly demonstrate their value for very, very little cost compared to the £40 million that we're trying to save up there that's churning away in acute trusts. The impact that you lot are having with these interventions is huge and long term, and we've got to get better at maintaining this stuff. Duncan.
Yeah, thanks, Richard. I think the thing that we've got to do is it's not necessarily about mainstreaming interventions. It's about mainstreaming the approach, because everything that we've heard today, we've got national services for this. We've got a maternity service. We've got national debt support systems. We've got a national smoking cessation service. But what we've heard from Abby, James and Carlton is that in areas of high inequalities, and we've almost got blanket deprivation across a lot of Bradford, we have to take these national programmes or these national approaches and adapt them locally. And that's what we've tried to do with Core20+5, is that it's essentially seed funded 70 different ideas and innovation from local communities. And this is the sort of event that we want to showcase those and say, look, this has got to be a way that we just do things as the norm in Bradford, is that we take these national policy initiatives or these national NHS initiatives that are very flat and delivered the same to everyone and adapt them locally for our population. And in the grand scheme of things, in our 1.4 billion budget for NHS and care in Bradford District and Craven, this is all very cheap. And the one thing that really annoys BCS organisations, and I know we'll know people on this call, is that we can't seem to get in a longer term cycle of funding. But all we can do is to keep innovating, showcasing this work, and try and make sure that it influences our core budgets across Bradford, rather than having to scrape around for bits of inequalities money. So that's why this is really important. I think it's the approach that should be scalable.
Well, there you go. I think there's no better closing word from our esteemed expert, an unblusterable leader for the Alliance. Despite what comes our way financially, we're still finding a way to keep this work going, and I applaud all of you for doing that. Thank you. It's really important work from where I'm sitting at the senior tables as well, that this carries on. We are over time by 3 minutes. I apologise. Sorry for chairing that a little slowly. I think that's the end of our session. What did I have to say? Was there anything at the end? Thank you for joining us. Everything will be on the website. Joe's done that already.
Thanks
Thanks,
so much.
Richard.
Thanks for sharing, Richard. Thank you.